again, this is really dear and near to my heart. So if I start foaming at the mouth, this is really what I live and I think about all the time. It's about your bladder. So this talk is going to take a little bit of a change because it's very practical. So not just for half of you here, perhaps with Parkinson's, but for those of you taking care of Parkinson's. As we get older, unfortunately, the bladder starts to cause all of us trouble. Okay, so hopefully I'll give you some tools, some things to think about, and I promise I will answer all of your questions. So if you just put down your email and give them to Aaron Daly or others collecting it, we'll be able to then compile and I'll answer all your questions and send it back to your email address. All right? So how much does it affect people with Parkinson's bladder problem? A lot. Some numbers, anywhere from 1/4 to 3/4 of Parkinson's patients will have some trouble with their bladder. All right? Usually it comes after you've been diagnosed, after some of the more typical Parkinson's symptoms. Of these, about half is what we call irritative symptoms. What does that mean? That means you have to go a lot more often. You have that urgency. It's gotta go, went, or almost went. You just can't hold it as well. Okay, having to wake up at night. All of those are making you have to go more. A little bit less is the obstructive, meaning you have trouble going. You're having to sit there a little bit longer, you have to push more, it's just not coming as easily as it used to. And then some have both. Okay, that's unfortunately the world of the bladder. Okay, it really doesn't give you very, very clear clues. But once it's starting to not work quite well, I really recommend you start telling somebody so that we can start working it through for you. This is really, really dear to me because I think this is almost a closet disease, our bladder and bowel. Okay, in some ways, I joke with my colleagues, but it's not really a joke. Like if you have cancer, you almost get more sympathy, right? Something you can tell people at a dinner party. This is not something you share widely at a dinner party if you want to be invited back to the next dinner party. But, there's those of us who really would like to change that, or at least give you some tools. So a little bit more technical, a big part of what's happening to your bladder is that the bladder is starting to have spasms. That's not normal. The bladder shouldn't spasm. Okay, your brain has a lot of control. We just don't think about this. You don't appreciate it after the age of 3, after your toilet trained. Really, right? How many of us really think about it? I think about it a lot. So what we find is that a lot of your bladders is spasming. And what you feel when the bladder spasms is just that you have an urge. That's not really the normal urge when you were 20. This is urge because the bladder is already squeezing. So unless you live over the toilet or have really strong muscles to fight that spasm, it's coming. All right, so therein lies the problem. And then the other side of Parkinson's is that your sphincter, the muscle that kind of squeezes, that we tell pregnant or moms who have babies to kind of squeeze that muscle to do the Kegel exercises, that muscle becomes a little slower and a little weaker. So you're not able to squeeze quite as hard. Even if, you haven't had kids and your wife had the kids, your sphincter may not be as strong, okay? Then there's another side. So I've just been telling you the bladder is overactive, it spasms, makes you have to go all the time. And then the damnedest thing is that then there are those that you may have to go a lot, but when you do go, you don't get everything out. Okay? The bladder doesn't work normally on that side either. It may spasm, but maybe it'll spasm only half of it out. So you still have about half left. And that can also cause issues. So if it's overactive, you can have incontinence because the spasm is pushing the urine out. But you can also have more urine left in. And what problems can that cause? Well, first of all, it'll just make your bladder fill up faster and have to go more. It kind of perpetuates that cycle of the spasm. But it can also cause infections if you hold enough in your bladder at a time, right? A flowing stream is always cleaner than a stagnant pond. So urine, we like it to come out, most of it. So this bit is actually really for the general population. It's not just for Parkinson's patients. Overactive bladder, what is it? Anyone who has to pee more often than that's normal. There's urgency involved, you just really can't hold it. There may be incontinence, leaking of the urine that you can't control, and having to wake up at night more than really once or twice as you when you become over the age of 65 or so. It affects a huge part of our population. Okay? About 33, 35 million. These numbers are quite old, about 10 years old. And as everyone's getting older and we're all living longer, we know these numbers are already higher. And it's only going to become higher. Again, this is just for the general population. As you know, with Parkinson's, you're at even higher risk for these bladder issues. It's actually the same between men and women, this overactivity of the bladder as we age. However, unfortunately for us gals, we do tend to have more of what we call wet OAB, which is the incontinence. Okay, the guys can just hold it a little bit better than we can. So why do I care so much? Yes, I'm a urologist. I like pee. I like to talk about it. Well, it really affects your life a lot more. This is your quality of life, all right? Because you avoid intimacy, you avoid relationships. It's a really important part of life. Okay, I truly believe, right? To the day you die, right? Huge depression association. Okay, we already know that as people become older, especially if they have other chronic diseases, depression is an issue. And this adds to it. I will be depressed too if I can't go out because I'm worried about, where there are bathrooms and things like that. A lot more falls. If in the middle of the night, you're having to wake up 2, 3, 4 times, right? It's often dark. You're trying to rush because your bladder is just screaming. What's the automatic? You trip on something, you break your hip. It's this downhill spiral that we really, really worry about. And you do have some increase in bladder infections, in UTIs. So a lot of things outside just your bladder that affects your quality of life. So the problem is, again, people don't talk about it. You may not talk to each other, your friends. A lot of people don't even talk to the doctors because it's part of the perception is that, well, it's just part of being older. Well, it's part of Parkinson's disease. Damn it, just stop that. It's not. It's not normal, okay? And we have things that we can do to help you. And for those of us who do this, we're not jumping to big surgeries. All the things that we have are all quite minimal, okay? Because again, this is a quality of life. If I do some big surgery and there are side effects, I've just hurt your quality of life, right? So that's not what we're about. So I want you to really think this through. When I teach, I want to stress that, we tend to ask you a lot of questions. And the reason is that there are different types of incontinence. There's no one kind of fix that just takes care of everything. So when you see a doctor, nurse practitioner, you want someone who really delves into exactly what you have. You may have a couple mixed. It's pretty common as we get older. But the reason is the treatments are different. So we want to target it to get the most bang for the buck. Okay, we may try one thing first, another, and do it together. But you want someone who really thinks this through for you, and not just say, "Oh yeah, let's just do this and it'll take care of everything." Again, it's a big mixed pot. It's very hard to pull together. Do you just have stress incontinence? That's when you cough and laugh. A lot of women have that. You cough, you laugh, you bend over and lift up something heavy, you lose a few drops. And then there's the urge incontinence, which is, oh, it's coming. Went. There's very little time for you to get to the bathroom. I have so many patients, they know every bathroom in the shopping area between the house and where you're going. Every shop that lets you use the bathroom. I have patients that tell me, yeah, I've got dollar bills ready so that I can just throw $1 on the Starbucks counter so I can run to the bathroom in the back. These are all things that we figure out, right, to do, to take care of it. So I want to give you a few more things to know. The nighttime PA, I just want to mention it. It's a whole animal unto itself. It's not just the bladder. Okay, we have a lot of things for you to do to help manage it, but it has to do with if there's fluid in your legs, during the day, if you have some swelling. It has to do with if you have sleep apnea. Okay, I'm going to throw out some little tidbits that you can ask your doctor. 50% of people with sleep apnea will have to get up at night more. All right, so it's definitely something worth thinking about if waking up at night is really your main problem. Just very few slides of what's wrong. to control peeing, it actually starts in the brain. And that's why diseases like Parkinson's or multiple sclerosis really affects the bladder. Okay, it's not really down here, it actually starts up there. And so it starts all the way in the brain, and it has to send these controlling signals down your spine, all the way down to the bladder, before these controls are in place. So as you're listening here, you're not running to the bathroom because there's an inhibition signal on your bladder so that it's not spasming away. And then when your bladder is full, that signal is released, but not until you get to a toilet and get your pants down, all right? Before that inhibition is released from the brain, that allows the bladder to then squeeze and let everything out. It's actually very complex, and I think it's very beautiful, but we don't actually know that every last nerve and signaling for it to happen. We just know that it's very complex. And that's why it's not just Parkinson's, it's multiple sclerosis, it's people who have strokes, people who have spine injuries, disc problems, that all come see. All right, so you're not alone. There are so many people with bladder problems. This is just showing that, then the other side switches on so that your bladder can squeeze and the urine can actually come out. So this is where the disease is, right? This is where the main urinary center is in the brain. So I'm gonna now we're gonna target therapies, just so you can hear everything that's available, okay? So that you can start kind of just have a basic idea. We always start with something that will not hurt you, okay? No side effects. Hence, the first line is what we call behavior modification. And that is actually watching your fluid, not drinking all the way up until you go to sleep at night. If you wake up 4 times to pee, you have to stop drinking about 2 hours before you go to bed, just so the water can kind of make it through your system, all right? There's some bladder retraining that's pretty simple, okay, that can be done. And finally, it's actually the Kegel exercise. It's what you do to squeeze your pelvic floor, you hold it, and then you relax. The relaxing is very important, but these are the squeezes that you should do every day, about 50 to 100 squeezes a day. The key is doing them. I don't really care how many you do, is trying to fit that in. Just kind of train yourself whenever you're doing something that's mindless, just do a few squeezes. You're listening to me, you should all be squeezing, okay? There should be 100 right there by the end of the conference, all right? We have handouts, I can easily give that to you. It doesn't really have side effects, it can help. The reason is that it's not just strengthening those sphincter muscles so that you can tighten. There's actually a reflex calming of the bladder so the bladder doesn't spasm, okay? There are studies that definitely have shown this. It shows that if you do these exercises, if you can remember, you can improve the incontinence drastically. The reason it doesn't work is that no one remembers to do them. That's really the bottom line. Okay, so even if you can remember a little bit, it's going to help at any age. Second line. So the first line, people don't pay as much attention. I highly recommend you do as much as you can, okay? The second line would get into drugs, medications. All medications have side effects. So the main group of medicines that we've been using for decades is something to help stop the contraction of the bladder, the spasm of the bladder, all right? It blocks, a chemical that's released that makes our bladder spasm. You've seen commercials from most of these on TV, okay? These are really the main players. A lot of them, several of them are same because one is an immediate release, another one's an extended release. You only need to take once a day, things like that. I just grouped them all together. The bottom line is there is no one star. I don't care what the commercials say, what your friends may say. You may get more benefit from one than another, hence it's worth trying at least, maybe a couple or a few, but there's no one, if you ask the doctor, what is the best one? No one should be able to tell you that. The problem with this is that it has a lot of side effects. Okay? The reason is that the receptor this medicine tries to block in your bladder also are very similar receptors from head to your toe. And your eyes, it makes your eyes dry, makes them blurry. Salivary gland makes your mouth dry, which is every drug makes your mouth dry, unfortunately. It can cause some heart palpitations. It has receptors in the colon, so it can make you constipated. So dry mouth and constipation are really the main side effect that this group of medicines cause, okay? So those are more of a tolerability issue, okay? It's irksome. If it's really bad, obviously we stop the medicine. But there are also a few other side effects that we worry a lot more about. It can cause some people not to think as clearly. That's a big problem. As I mentioned, it can cause some heart irregularities. These are very minor, but they can happen. So when someone gives you a medicine for your bladder, when I do, we watch the patients quite closely. Usually we tell the family to watch them quite closely, because if they're not thinking too clearly, they're not usually one who knows, right? So drugs are not benign, right? I think we all know that. There's a brand new class of medicines for the bladder, just out last year. Very exciting for us. Doesn't mean it's, again, the magic star that works great to control your bladder spasms. But the side effects are very different. So I find that very, very useful, because if your mouth is so dry you can't even talk from these drugs, then you know what? We're going to try this new one. It relaxes the bladder, same idea, but the side effect is that it gives you a little bit of high blood pressure and gives you this runny nose, stuffy nose side effect. Okay, so at least we have a new medicine that gives us some choices. So that's very exciting for us. I forgot to write the name down, sorry. Mirror background is the name of the new medicine. Third line now. Okay, the pills are relatively easy to take. You know, you take it, doesn't work, you stop it. Still relatively easy. The third line therapies are a little bit more invasive. But again, as I say, all very superficial. I will be comfortable letting my 95-year-old grandmother try any of these. Okay, so they're broken into two big categories. One is actually nerve stimulation. So some of you are probably experts on deep brain stimulation. Dr. Ostrens will be talking about. So we have something very similar. That's for your bladder nerves. All right. So there's two ways of stimulating your bladder nerves. I'll mention a little bit. And then something that we've been able to do for more and more patients is that I can inject the medicine into your bladder to just calm those spasms. That's Botox. A little bit for your forehead, a little bit for your bladder. We're beautiful inside and out. All right, so I'll mention a little bit more in depth. The first way to calm the bladder down by this nerve stimulation is actually, there's a point right at your ankle. It's actually a major acupuncture point, but it hits the nerve that's coming out from the bladder. So it's a peripheral nerve. It's not the direct bladder nerve. So the idea is that we put an acupuncture needle to that point. We clip a little electrode to that needle, so it's stimulating nerve. And we're thinking maybe kind of like backwards signal. It goes back to the bladder and calms it down. The way it usually, we prescribe it is that once a week you have to come in, and we try for about 3 months. So about 10 to 12 sessions. Okay, it's pretty minimal, doesn't really hurt, but it's time. So there are some people who say, there's no way I can come see you every week. And so, so we put that lower down on the list of things to try. So this is how you need to think about some of these treatments. Because what's nice about all of this is that there really isn't, even though there's first, second, third line, that's really just based on how, what the side effects are, right? Less side effect, first line. But the rest of these, we can try one, doesn't work, we can try the other. There's no exact 1, 2, 3. Okay, I don't want you to feel like, oh my God, I have to pick the best one, then, there's none of that. So about 12 weeks, we need to try that. The second one that I find that probably works a bit better is a direct stimulation to your bladder nerve. So this is what we call our bladder pacemaker, actually, okay? It was invented in our department at UCSF, in the urology department, and it's been in use for really decades now. Where it targets is that very low down in your tailbone is where your bladder nerve leaves your spine. So we tried to put a little wire right in that area to stimulate this urinary center that's actually low down. There's one in your brain, and there's another one low down in your tailbone area. All right, so that's the area we're trying to aim for. So what I'm able to do is that I can just put a tiny little wire through your tailbone. The beauty of that is that it doesn't hurt anything. It's so low down that there's no danger of paralysis. I won't make you, paraplegic. I won't hit anything really that important. We just want to put a little wire into your tailbone to put it near the bladder nerves, as close as I can get. And then we stimulate that. Okay, so initially we try it for 1 to 2 weeks where there'll be a little wire coming out of your back, but you have a little temporary battery like a pager that's hooked to. And you can test it to see whether or not it's actually calming down your bladder. You may say, oh, I used to go 20 times a day. Now I'm down to 10. So it's really completely based on your sense of how well it's working or not. Because so it helps with frequency, helps with urgency, the incontinence. What's very exciting is that what we've known for a while is that it helps with fecal urgency and incontinence. What's exciting is that the FDA in the United States just approved it about a year or so ago. Actually more than a year ago, but it's just starting to be used. So I've always known this because I see patients with bladder and bowel problems, and my God, I have something that can kill 2 birds with 1 stone. So definitely something to keep in mind. And maybe, to be honest, this is what patients teach me. The bowel problem is a lot harder to hide. So many of them are actually much more thrilled when I can actually take care of that, even more than the bladder. So after the first week or two, if you say, Dr. Deng, I think this is definitely helping me, it's a goal. So if you have at least 50% improvement that you feel, what I will be able to do is put in a tiny little battery about this size, pretty thin. I can put it underneath the skin and a bit of the fat kind of behind the upper butt area, okay, the hip area, and then everything will be connected underneath the skin. So you won't have anything hanging out of the body. And that's essentially a bladder pacemaker. And this is more than really just a little battery. It's like a little computer where we can program it, we can adjust it. You have a controller that you can turn it up and down, on and off, so that we have some control to adjust it once it's implanted. So it's something that really, definitely can be thought about. Very safe, reversible, really not very hard for me to take everything out, to pull out if for whatever reason it doesn't work. Some of the side effects, like some people complain about that there's some pain, obviously. It's a minor surgery. It can get infected, although that's actually quite low. I've had very few patients that's happened to. And the good thing is if it doesn't work, we can actually try something else. Even without taking it out, we can just turn it off for a period of time. Okay, so the one caveat is that you cannot get an MRI when you have any implants, as you probably know. And that goes for orthopedic things as well. So it goes for what we put in, mainly the little battery part. So you can get a brain MRI. It's quite safe. They've okayed that. But the spine MRI is still not recommended. And the truth is, it's not as if something will explode inside of you. The worry is that the little battery gets hot, okay, because of the magnet of the MRI. Of course, the company, no one's going to say that. It's safe for you, so we get into a little bit of quandary. So sometimes I pick it out for a patient who needs an MRI urgently for some reason, and we go through it. Some other things you need to know that you might set off some detectors, theft detectors when you go shopping and whatnot. You don't get electrocuted, but there may be some of that. But most important to the airport, we need to give you a letter and whatnot, so they warned you so you don't walk through their X-ray machines and things like that. That's all. Pretty minor. I have not heard in my 10 plus years of doing this. I haven't had patients coming back yelling at me because something terrible like that happened. So that's our nerve stimulation kind of therapies. Now really Botox. Okay, a lot of people are familiar with it, for the wrinkles, for your vocal cords, but we've been able to use Botox in the bladder really for the last 10 years. It's just been FDA approved in the last couple of years to be used in the United States, with FDA approval. The same idea. It's trying to block the spasm, the contraction muscles in the bladder. But I'm able to inject this directly into the bladder. So without you having to take a pill that has then absorbed through the blood and then maybe go to the bladder, but also go to your, your salivary glands, your colon, everywhere else. This I can put directly to the bladder. So the effect is quite good, very easily done. The little scopes that we use to look inside your bladder, okay, with people awake, really. We don't have to actually anesthetize you much or any for that. Then I can put a very small needle through and we just give you a bunch of shots in your bladder. We soak your bladder with some numbing solution beforehand because, we are truly not cruel. We would like to prevent the pain even from the small needle shots. So that's what it looks like, when I do that with a little needle. Everything's very magnified. So I've actually learned to show the patient the needle before they see it on the screen, which is horribly magnified. I've heard this sucking in of the breath, of the family seeing it, thinking that I'm like putting some harpoon in their bladder. So I've finally learned to look, this is really how small it is. So FDA approved now. Success really can be life-changing for some of the patients, meaning no more pads, okay, until the Botox wears off, about 6 months. So anywhere from 4 to 6 months, each person is a little bit different, but I can usually get most patients to the 5-6 months. They come back, we do this round. I have patients that's been with me literally for almost 8-9 years where they never miss that appointment. They know when it's coming up, we have a book. I have patients that flies up from San Diego who just, will not have it done anywhere else. And then there's some that doesn't work, so we adjust the dosing a little bit. But this has a side effect because we're trying to calm the bladder contractions, right? So what can happen? If it works too well, your bladder is really calm. So you may not be running to the bathroom, but when you do want to pee, it doesn't really come out. So urinary retention, more incomplete bladder emptying is an issue. Maybe about 10% of patients, so 10 out of 100 will have it bad enough where we may need to teach you how to use a catheter temporarily. So we don't like to leave a catheter in anybody. So usually we try to teach patients to put a catheter in themselves maybe 3-4 times a day, just so you can get all the urine out of your bladder. All right, sounds a hideous thing, but something we do. You're perfectly capable, but again, it's only about 10% of patients. If you already have some issue with not being able to pee very well, obviously your risk might go up a little bit. But but our job is to really help you and support you through all of that. So it's not as if we inject the Botox, good luck, see you in 6 months, you can't pee, And so definitely, it's all about quality of life. So we definitely will take care of you. All right, go through all of that. So this matters, right? May not be something we talk about with everyone, but this is a really, really big part of all of our quality of life. And so most commonly for Parkinson's patients is this overactivity of the bladder that you just can't quite hold. But some also has the problem of not being able to pee and get it out. And because Parkinson's hit men, as you know, more, and because it tends to be older men, you have to be very careful. I want to tell you this so that when you see urologists, other people, because we like to blame any peeing problem in the older guy on your prostate. Because you have one, and we don't, okay? And rightly so, joking aside, because the prostate does cause bladder and urinary problems. But you have to be very careful. If you have Parkinson's and someone says, oh yeah, we're just gonna shave that prostate, or we're gonna do a rotor-rooter, everything will be great, you should talk to someone else, just as a second opinion. All right, because there's a lot of subtleties with that you worry about, because people tend to be, if you have Parkinson's, you get a TURP or rotor-rooter job where we cut the prostate a little bit to open up the urinary channel, your chance of being incontinent is actually much higher. So all of those things need to be looked at. We need to figure out, is it really your prostate that we can blame, or is it really your bladder? And we should target that first. Those are just the minor subtleties that I just want you to know a little bit about. So we have lots of different tricks up our sleeves. Okay, it's not just Kegel exercises and some pills. So there's a lot more that we can do. And I really hope that if you have any issues, we would love to at least have a chat and give you some of these tools. And so my email address, phone number for my assistant, and also the main number to the urology department. I have a partner who does what I do. We also have a nurse practitioner. So there's lots of us to just start the conversation for you, okay? That email address, you cannot write any clinical information, so don't tell me your whole history on there because I have to delete it, otherwise I get into a lot of trouble. But if you, just make it somewhat vague, anonymous, all right? And finally, please write down your questions with your email address. I will answer all of your questions and send it back to you. Thank you so, so much.